Good afternoon, everybody. I am again back with an interesting case, I always say. But let me tell you, and I profess here, that this case has also taught me a lot of things which I had forgotten. It again emphasizes that you have to start solving a case right from the history. And this has also taught me again that certain things are very important which you forget, then it is little difficult to make a diagnosis. This was a 2-year-old child who came to us in the emergency with seizures. It was a 2-year-old, the child was absolutely all right. The child never had any fever, there was no history of any trauma, and this child had no loose motions, that case only came with the attacks of the generalized seizures. As the protocol is, the child was started on given injectable benzodiazepines. Of course, the seizures would not stop, so we had to give a higher dose of benzodiazepine. So much so that it was a case of a refractory seizure. So one shot of Livera was given, levocetizine. So much so, in between the child was all right, then again the child used to have the seizures, and we had to increase the dose of the Livera, and so much so that another second anticonvulsant also had to be added, which was in the form of phenobarbital. Now I get a call from my senior resident that, sir, abhi bhi iske seizures are not being controlled. So I telephonically also said, since the seizures are not being controlled, you put this patient on midazolam infusion. And the child was started on midazolam infusion. Now what happened, after giving midazolam, the child's seizures got controlled. But what we found, that after one day, the child again started having pin rolling movements of one of the hands. We'll show in the video. We have recorded that video. The child is not at present with us, but that was characteristically showing us that there were movements, and mother was very characteristically telling us that these pin rolling movements of the hands disappear during sleep. So most likely they were extrapyramidal in nature. So that was all in the history. Anybody would like to say anything, or anybody like to ask me anything which I have forgotten? Mukesh? Nothing. So keeping those things in mind, then I'll just tell you in the history, where I always say this is the history done during the course of the movement, course of the treatment. And during the course of the treatment, also this child received one blood transfusion at a later date, of course, not now, because the child was quite pale. Going back to the history, the birth history was okay. The child was normal vaginal delivery, full-term baby. It was the antenatal natal period was all uneventful. Immunization history was as per the age. The child was developmentally normal for 2 years of age. Now, this is all was taken in the history. So I'll go back to you that what we had forgotten in this child. Now, on general physical examination, when we found the child was moderately pale, child had no hepatosplenomegaly. On the general physical examination, the vitals are all well maintained. One of the residents did find that maybe the child has got some respiratory distress, and it was advised to go in for an X-ray chest. Right. Now, seizures, as I said, if they were very recalcitrant seizures, so we had to use midazolam infusion, which was going on for 1 or 2 days. Meanwhile, the investigations had come. Investigations had revealed a hemoglobin of about 6.6 gram %. TLC was within normal limits, platelet count was okay. We had sent the kidney function test, blood urea was 38, serum creat was 0.5, sodium was 140, potassium was 4.5, and ICAL level was also 0.8. So ICAL, there was no evidence of any hypocalcemia. Blood sugar of the child was 100 milligram percent. LFT was also within normal limits. Since the child was in altered state of mind, maybe because of drugs as well, and the ABG was also done and ABG was also normal. Now, keeping all those things in mind, any specific investigation you would like to ask for? You are sitting here, Manish. Most important thing which you will ask, which I have not yet enumerated, I have kept at the back. I'll ask you. The child comes to us with seizures, no history of fever, recalcitrant seizures, very difficult, hard to treat.
For EEG?
EEG, that is what you feel. Why will you not? EEG तो यहाँ होता नहीं है. सबसे पहली चीज़ होती है, you will go in for an LP, lumbar puncture. I have withheld. So lumbar puncture has to be done. So बात EEG की करोगे? You see, that is what is happening. All modern day doctors are talking of EEGs, CT scans, MRIs, and our basics they just forget. And I am telling you that I also forgot some basics. So the LP was done. It was acellular. Protein was less than 100. Sugar was about 66. So it was all okay. So it was a normal. Now in a child who is in this state, two things I would like to ask, because I was asking two things. Sushma can answer. There are two things. One is it could be a case of an encephalopathy, or it could be a case of an encephalitis. Now, what is the difference between encephalopathy and encephalitis?
Sir, encephalitis is inflammation. So there, encephalitis is inflammation. Sir, inflammatory markers will be raised, and
inflammatory markers.
Sir, in CSF we will get WBCs will also be increased in.
There may be a lymphocytic response.
Yes. Sir.
Proteins may be raised.
And glucose will be.
So if there is no history of fever also. So fever, if it is there, maybe viral fever. So it is a, as you rightly said, it could be inflammation. And what is encephalopathy?
So that is.
What's your name?
Sir, Deepak.
Deepak. So give it the mic to Deepak. Deepak, what is encephalopathy?
Sir,
it's a very simple question which we ask in exams.
Insult to brain without
encephalopathy and encephalitis.
Sir, insult to brain without inflammation.
Very good. So there is a defect in the brain function without any defect in the structures. Right. So could you tell me some causes of the encephalopathy? Very common causes in pediatric age group.
Lead encephalopathy, sir. Sir, lead encephalopathy.
Lead encephalopathy, which is so uncommon.
Hepatic
and CAF. Say hepatic and CAF.
Yes, sir.
Electrolyte imbalances can cause toxogenic enteric encephalopathy. So where basically it is an enteric toxins go, this is toxic encephalopathy. So you are talking of a rare things again. Talk of the common thing, which is, as I rightly said by Dr. Suchit, as hepatic encephalopathy. On examination, of course, this child never had any icterus, no hepatosplenomegaly. But yes, you must keep that in mind. Now this was a child most likely of an encephalopathy. His brain functions were altered. Now what happened? Next very day, one of the residents who came to our rescue got an X-ray done, as I said, and that X-ray was revealing few things which we thought. I'll show you the X-ray later, but after seeing those X-rays, I thought why we have forgotten one important history in this child, which I again emphasize, and that is called the occupational history or a family history. So the family history of this child was not taken. Normally also we don't take any family history when a child comes to us with seizures, which we must take it. This was, on the contrary, a message should go that if you have any atypical features, things are not, normally the seizures get controlled. Here the seizure never got controlled after giving 2 drugs, and we had to give an infusion of the midazolam. So when we talk to the family, the father lives at the first floor, and there is a factory of toys on the ground floor. The fellow does the packaging of those plastic toys. So as you keep in mind, if you have this kind of a child, then straight away by the history, it came to our mind with an X-ray with us also that maybe we are dealing with a case of a lead. So it was a case of a lead intoxication. I must tell you, this is not very common. I am seeing after about 35 years this case, and that initial earlier case was, but again, you are yelling. I am telling you this is because if your mind knows, the eyes would see. So in this area, in this era of strict legislation also, you must try to keep in mind and must try to take a detailed family history. So this child, the father was in the packaging, and the earlier case which I saw of a refractory anemia, there also we came to know later that the father was working in a area in a industry of the batteries, manufacturing of batteries or repair of batteries. So that is what I wanted to emphasize, that this was a child of most likely lead intoxication. Now, what investigations I asked for? I ordered for a blood lead levels. Now lead, you see, lead causes a lot of problems. Lead is used in many industries, and if you go back to the history, lead was initially started off it used to be in the gasoline, so they made lead-free gasoline. Now lead used molder in the pipes also. You try to repair the pipes, that is what is called plumbism. Chronically, the lead is one thing which has got a very low melting point. So it can be used in the toys industry, it can come to the child from the soil, from the water. So there are so many causes of lead. We in the neonatal period, you will ask, बच्चों को कहते हैं ना सुरमा मत लगाओ, काजल मत लगाओ. All those kajal, surmas, they also contain lead also. So this should ideally be avoided. Now, having seen that, I'll just talk to you. The lead levels of this child were more than 100 microgram per deciliter. The safe limit, of course, when I was reading my book after so many years, the safe limit is not defined, but yes, usually the lead levels are less than 5 microgram per deciliter. And in Nelson textbook, it is mentioned that around more than 100 microgram per deciliter is almost fatal. And this is what unfortunately happened with this child. We had used the chelators, but this child finally succumbed. Now, most important things here I would like to say, peripheral smear, of course, had not revealed that basophilic stippling, polychromatophilia, but yes, it was microcytic hypochromic type of RBCs were there. I will show you the X-rays, which you will appreciate these X-rays. We also just come closer, you can see. Now what is happening is, focus karo yaar isko. See, now what is happening is, you see this X-ray, the metaphyseal bands, they are sclerotic. There is thickening of the bones, there is sclerosis here, and see here, this is the lower part of the even fibula or tibia. You find sclerotic band, the metaphyseal. You see, I had sent these X-rays to one of my colleagues working with the Dr. Vinita Rathi. She will also, I will put that, I will take her views also, and she was also feeling that this could be, if the history is all there, this could be lead. Now see this X-ray of the chest, which we got it done and from which we clinched the diagnosis. See, both the humeri are almost sclerotic. See the rib cage is also a little more dense. So it's like osteopetrosis, but then the setting is not there like an osteopetrosis. The differential diagnosis also has been discussed by her. A picture where you have a sclerosis, you have the bands of sclerosis on the upper ends, which was seen in the tibia, femori. So what is the differential diagnosis? If I may ask Bankhudi that what could be the differential diagnosis of this kind of a, just mention, we'll talk about it. Of course, she's talking about it in the differential diagnosis.
So firstly, we have to rule out any nutritional deficiencies like rickets and scurvy.
Rickets, it will not be a florid rickets. You must say it is a treated rickets or healing rickets.
Okay.
Don't talk of rickets alone. The picture is not like this. The picture is of a healing rickets. One. Anything else?
So vitamin C deficiency, scurvy.
Hypervitaminosis D. It's not scurvy. You are again and again going back. You see, let me tell you, one of the fellows had kept a possibility of scurvy and got the limbs, X-ray of the limbs done. But again, I am telling you that this is not a picture of scurvy. This is a sclerosis is there, which is usually not seen. So the differential diagnosis, usually you have hypervitaminosis D, hypoparathyroidism, hyperparathyroidism. So all those things will be discussed by one of my colleagues.
X-ray both knee joints of this 2-year-old child shows dense metaphyseal bands. These are seen at the lower ends of both femori and the upper end of both tibia, and you can also see them at the upper end of both fibulae. So you can see the area of sclerosis here. X-ray chest AP view of the same child shows a generalized increase in bone density, as you can see in the ribs and the vertebrae. And in addition, you can see that at both proximal ends of humeri at the shoulders, there are those dense metaphyseal bands which we saw at the knee joint also. So these are very characteristic of lead poisoning if we have a relevant history. Dense metaphyseal bands also has a long list of differential diagnosis. First of all, it can be a normal variant. A dense zone of provisional calcification may be seen in neonates at the metaphyseal ends of bones. It can also be seen in healing rickets. Then there are other metabolic disorders like hypervitaminosis D, hyperparathyroidism, hypoparathyroidism, pseudo-hypoparathyroidism. These can also present with dense metaphyseal bands in bones. In patients with osteopetrosis, we sometimes see these dense metaphyseal bands, but there are other radiological features in association. That is, the lower ends of femurs will be broad and flask shaped, called the Erlenmeyer flask deformity, and other changes in the spine like bone within a bone appearance. Other heavy metal poisoning like bismuth, arsenic, mercury, lithium, etc. can also lead to dense metaphyseal bands.
Now, since this child was in encephalopathy at a very high level of lead levels, let me just pass on and saying that there are 4 kinds of chelators which are used in such cases. Usually lead is, you must know the sources, how a child gets into it. Child gets into it because there is a habit of putting everything into the mouth, and that is the most common thing, that is ingestion. So some toys, even imported toys, even you see some candies also can have some lead. So if they eat, in this case, maybe the child was putting into the mouth. Now let me tell you, this child is 2 years of age and has got changes in the bone. That means it is not acute. It has to be a chronic exposure of lead, and this must be either through the ingestion or inhalational. What is inhalational? From the paints, from the dust, the child also might take it through the respiratory tract. Now what happens is, you can read all this in the textbook, I'll be very brief here, that this lead, the other important thing was when I was reading is that even the transplacental spread. So it's a very free, lead can go out into the, what happens with the lead is it can be transplacental, and there could be in a younger child, lesser than 1 year, if there is a bony involvement, there could be a transplacental spread. Now how does lead affect? Lead, basically you must understand two things. That lead is inhibiting a lot of cellular enzymes in the metabolism. Most common is as I said, in the refractory anemia. What is happening is when there is a heme formation, in the heme formation there are so many enzymes are there, and I think the last enzyme is ferrochelatase, and there is heme formation is not there because it inhibits the heme formation. Then heme will get into the globin. Now it basically inhibit the iron. Iron has to get into the last stage to get into the heme. The lead will come here. Lead will not allow the iron to bound to the in the heme. So heme is not there. In the last stage, iron has to be there. So when the iron is not getting absorbed, that is why there is iron deficiency anemia. That is the pathogenesis, which you understand. So if you have a refractory anemia, because iron is not being added, okay. Now what is happening here is why there is encephalopathy, because basically what is happening, as I said, it inhibits a lot of enzymes. Now these neurotransmitters which are through the calcium, they also get inhibited. Iron gets inhibited, calcium is not there, so these neurotransmitters in which there you have an element of calcium is required. That is why these children go in for encephalopathy. So iron you must understand. Even lead also can cause kidney problems, renal tubular dysfunctions. So all those things you can read those in the books. But yes, I must tell you that important thing or the message which in the end I would like to say, whenever you have the atypical features of any child which you can't explain, in here we could not explain so much of recalcitrant seizures. So you have to go back to your basics. As I said, I also admit we did not ask the occupational history, family history, and family history clicks me the diagnosis, and I thank that resident who got the X-ray chest done, basically thinking it to be pneumonia, that we could see the sclerotic areas in the end of the humeri. So the message is very clear that you must always start with a good history. Isha, you understand? A good history is very important. And in this history, you could find out this could be a case of a lead encephalopathy. I was talking about the chelators, which you can read it. There are 2 oral chelators, there are 2 injectables. That DMSA or succinar is an oral, penicillamine is an oral, and then 2 you have got it when it's calcium EDT8 and dimercaprol. So those things are IV, they are given in the parenteral doses. But yes, when is to be given, though all things are in the book. But here in this child we did start because the child had a good high level of 100 microgram per deciliter. The child had encephalopathy, higher values, so we had to start on 2 drugs we started in this child, and those 2 also parenteral. But in spite of all those measures, the child succumbed after 2 to 3 days. So the message again is that again you must keep in mind these things also, they do occur, and you may pick it up much earlier if you have in the back of mind. Thank you.